So today's talk is on joy, suffering, and the goals of medicine, which is also the title of a paper I wrote with Bob and Cindy. And I think it's actually important, all three big words here, joy, suffering, and goals, I think are worth thinking about as we think about what we're doing in the world of medicine. There's a disclosure slide, and joy has actually become increasingly part of the work that I'm doing. So I'll share with you a new research project coming off the ground where we are specifically looking at joy and using a positive medicine approach, and hoping that this informs not only my work, but work of other people. And I've been inspired by other people who are doing work in this field. So my objectives are, first of all, before even talking about joy and suffering, for us to just take a step back and think about what the goals of medicine are. I think it may be something that seems obvious until we really start to think about it. And I think there's also a discrepancy sometimes between what our stated goals are and what the goals of our systems that we work in seem to be. And so I think that's worth thinking about and taking a look at. We'll talk about joy in the context of the care of people with serious illness, and as a counterpoint to suffering, both of those being subjective and person-centered experiences. And I'll talk about why I feel like those are so important. We can talk about opportunities in research, but directly in everyday clinical care to think about positive interventions of ways to bring joy, meaning, and connection into the lives of people living with serious illness. Lastly, we'll think about ways to incorporate joy into your career in healthcare. I know there's actually a lot of advocates on the call, so it could be part of your advocacy work, could be part of your work as a care partner in education and clinical care. And for me, every time I give a talk, and I think particularly with this talk, I'm looking forward to a conversation at the end so that I can get some new ideas and new directions for this work. So just to put this into some context, neurologists are medicine's leaders in burnout. And even if we go outside of neurology, burnout is kind of a global crisis right now in medicine. And I think it's really been accelerated. This was before COVID started, and I think things have really been accelerating. Nursing shortages, also in part related to burnout. So I think it's something that in the world of medicine, we really need to think a lot about. Part of this is due to external factors, COVID certainly being one of those, electronic medical records, documentation demands, workforce shortages, which make it tougher for the people who are still in medicine to keep from burning out. So those are, certainly very real factors. There are personal factors that can relate to burnout, and those, could include things around self-care, around sleep, around work hours. At the beginning of the burnout crisis, there was a lot of movement, I think, and I think a lot of this is well-meaning to look at wellness initiatives, to think about yoga and meditation, and those things are certainly important, but they're not the whole story. That there are external factors that need to be addressed as well. There are organizational factors, and I think the University of Rochester is taking wellness and burnout very seriously. The Mayo Clinic, I know, has been at the leading edge of trying to take an organizational approach to studying and addressing burnout. So, and then there are certainly organizations who aren't taking this as seriously and may be contributing to burnout in the people who are working there. Moral distress, I think, is an important distinction to make from burnout, which is that people may feel morally divided in terms of the goals of their work and then the demands of their workplace. So as an example, Fahad Saeed, who is here in nephrology, talks about challenges that nephrology residents face when they are being asked to put people on dialysis who they feel ethically may not really benefit from dialysis, but there are business motivations that could be contributing to that. And so there are various levels of moral distress that come up. Some of them may have ethical implications, some don't. Just in day-to-day work in medicine, there are things that are morally distressing that we may not be able to resolve. And lastly, and this is very pertinent to this talk, are cultural factors. So what do we think about in medicine? How do we talk to each other? How do we treat each other? All of those types of cultural factors, I think, are important in medicine and in neurology in particular, and something that I've been pushing for a while is the idea that taking a palliative care perspective and a palliative care approach may help mitigate burnout in neurologists and in other people in medicine, because we're able to engage with suffering, we're able to engage with the people in front of us in a more direct way. Whereas if we are culturally distancing ourselves, or we have a quote, professional distance or professional boundary from the people that we're serving and the people that we're working with, then that can lead to senses of isolation and may contribute to burnout. On the flip side of this, and I think equally important, and this is one of the themes of this talk, is that anything that we can look at in a negative lens can also be looked at in a positive lens. And so in addition to thinking about the causes of burnout, ways to combat burnout, how can we measure and how can we increase engagement? And so these are some questions that I think get at this, and you'll see these are some of the same questions that I will ask people who come to see me in clinic when I'm trying to understand joy in a clinical context, but these are also true in a professional context or in a personal context. So what is your job as a neurologist, as a nurse, as a medical assistant? And really tying into that bigger picture is what are the goals of medicine? What are we trying to do here? And I think I can speak for most people here that it's not about just getting a paycheck, that it's really here potentially to help people, and we can go a little bit deeper into what we mean by helping people, but what are our really driving goals, and what's our mission and vision? Related to that, where do you find meaning? And in this context, where do you find meaning in your work? Where do you find joy in your work? And where do you find connection? And I think asking these questions are equally relevant to asking questions about burnout, and may provide some of the answers for clinicians, and we're going to circle back around to this. Actually, if people can mute themselves, and Josh, if you're able as host to mute everybody except me, that'd be appreciated. Thank you. It is to ask these positive questions. So where do you find meaning? Where do you find joy? Where do you find connection? And as I said, we'll circle back around to this again at the end of the talk as a way to use this concept of positive medicine and joy to try to help with the burnout crisis. There have been consensus projects articulating the goals of medicine, and thus far, joy has not made the cut. I think the most definitive of these has been by the Hastings Center, and this was done, I think it's about 2 decades ago now. And they articulated 4 goals of medicine, which I think are well thought out, and I think most people would agree with them. The first being the prevention of disease and injury, and the promotion and maintenance of health. And this is already getting into ideas about wellness and some ideas of positive medicine and thriving. The relief of pain and suffering caused by maladies, and we'll talk more about this, but there is a distinction between pain and suffering, suffering being a much more subjective phenomenon, and one that really ties into people's personal sense of meaning. The care and cure of those with the malady, and the care of those who cannot be cured, and the avoidance of premature death, and the pursuit of a peaceful death. So I think these are, goals that most of us could agree about. When we look at what's happening in the world, we may expand these goals. So you're able to see my arrow here. Education is certainly a goal of medicine, and it's a goal of academic medical centers like the University of Rochester. Providing outstanding care and pushing the boundaries of what we're able to do with technology. Public health is a big thing, and gets into some of these things with prevention of disease. Research and pushing forward the science of medicine, developing new cures. And I guess from my perspective, I might say, unfortunately, just because I feel like it's tied into a lot of problems, but there is a business side of medicine. And that absolutely affects and influences what we do, particularly in the United States, but really in all nations, that socialized medicine is not a panacea either, and every system is going to be constrained by resources. So who determines medicine's goals? So this was a cartoon that I actually brought into my blog about person-centered care. And in this, we have some bureaucrat who maybe an insurance company who says, you just can't be trusted with making medical decisions, leave that to us. The doctor is saying, but I'm the board certified MD. And then the patient says, but it's my body. So we have various levels of stakeholders. I think in terms of the size and the influence that we should be reversing this, where the person with an illness should be driving the ship, but unfortunately that's not the case in our current healthcare setting. And this is an article Ray Dorsey wrote with George Ritzer, which is an article I love. I cite it all the time on the McDonaldization of medicine. But again, getting into this point of the business of medicine is threatening the business, or we might say the goals of medicine. And if you look through this table from their article, if you think about fast food or you think about medicine, these dimensions of efficiency, calculability, predictability, control, and we can certainly add to this, are absolutely influencing the practice of medicine and are contributing to, I would say, not only burnout, but potentially impacting the quality of care. And so I bring this up also to the point is that if we don't think about explicitly of the goals of medicine, other people will, and other people will fill in this vacuum or void in meaning. And I feel like the physicians, the American Medical Association has absolutely missed opportunities to take ownership of these issues. I'm all for peaceful revolutions, and I believe that we can make change, and I think this is a time where change is right, but it's definitely going to take a push, and it's definitely going to take a lot of thoughtfulness in order to change things from this current state of affairs. So to kind of switch gears from goals, another way of defining goals might be, how do we define victories as healthcare providers? There's kind of been three major models of how to do this. One is a disease model, or what's been called the biomedical model. A second would be a patient-centered model, or the biopsychosocial model, which was really developed here at Rochester. And then I would add a third model, which has been around actually for a very long time, is a person-centered model, which goes beyond the biopsychosocial model to include spirituality, but also to shift from patient to person. So if we start off with thinking about victory in this biomedical model or disease-centered framework, this is, I think what most people who start medicine or who are not in medicine and look at it think about. So the idea here is going back to our big goals to cure and prevent disease, to treat medical symptoms. And this works very well for acute illnesses. So if you're in the emergency department and you break your ankle, you want to get this thing fixed. You don't want to have an hour-long discussion about goals of your life or suffering or anything like that. You just want to get your ankle fixed. I guess also making the point that these are complementary models. They're not exclusive. But that being said, is that this model, I think, is limited, and it's particularly limited for chronic serious illnesses, things like cancer, like Parkinson's, like Alzheimer's, like most of the things that we see in neurology. And so if an illness is incurable, the disease-centered framework actually makes people feel worse because they end up losing the battle. And we have all these war analogies, and there's been studies actually showing that when people use these metaphors for incurable illnesses, that it actually leads to distress for both the providers and for patients. There are non-medical sources of suffering that fall outside of this framework. And that's true for people living with an illness who may be experiencing grief and loss and spiritual distress. And it's also true for family members of somebody living with an illness who aren't even included in this framework at all. And clinicians and others often feel helpless and hopeless. And I think this culture of that the biomedical model inculcates is really part of the distress I believe neurologists are feeling, who are seeing illnesses that really don't allow for victories using this framework. So kind of moving to the other circle of patient-centered care, which can be defined with palliative care, can be defined with the biopsychosocial model. But I would say the distinguishing feature here is that it addresses the total pain of serious illness, which is a concept that was developed by Dame Cicely Saunders, who's really the founder of modern palliative care. And so in addition to medical symptoms and diseases, we also work with difficult emotions. We work with spiritual and existential distress. We provide practical support and social support for patients and families. And then we dive deeper into medical and psychiatric symptoms. And this is a model that works better, certainly for serious illnesses, but also, I believe, has its limitations. So some sources of suffering are intractable. And being fully alive, I would argue, is more than the absence of suffering and more than the absence of disease. And in fact, is also possible even in the presence of suffering and even in the presence of disease. This is one of my favorite books, The Nature of Suffering and the Goals of Medicine by Eric Cassell. And he delves into great detail in both the practical aspects and the philosophical aspects of how do we define suffering in medicine. And at the core of it, he makes a very strong case that suffering is going to be individual and personal. So I'm not going to be able to predict what suffering is for another individual without understanding the context of that person and understanding the meaning they make out of their current situation. A great example of this actually came from physicians in World War II, Henry Beecher, who observed that when he was working as a physician in Brooklyn, people would come in with an injury and experience great pain. And part of that was the context of how that injury occurred. So it may have happened at work, and it means that they're going to be out of work. It's going to be out of doing activities that they want to do with their family. People with the same injury in the battlefield oftentimes not only reported less pain, but had less need for narcotics. And again, the context is that this injury was their ticket home. So wouldn't be able to predict it simply based on the biomedical model. Here on the right side portion is just a diagram of, again, Dame Cicely Saunders' idea, but that social aspects, psychological aspects, physical aspects, and spiritual aspects all are part of the total pain or the total suffering that an individual is going through. So there's clearly a lot of value added in this model that is missing in the biomedical model. There have been great strides in medical care to become increasingly patient-centered. The Patient-Centered Outcomes Research Institute has been part of this, but even before they came into creation, patient-reported outcomes were becoming more popular. And I think there's been a greater focus on looking at the patient and not just the disease to define our goals, which is a very positive movement. That being said, the biomedical model is still the dominant model in medicine. And George Engel, who was here at URMC, wrote an influential paper in Science in 1977. And 2 decades later, we're still arguing whether we've made a lot of progress. And I think we have made some progress for sure, and the conversations we're having are different. But fully incorporating the social determinants of health, really bringing in this idea of concept of total pain, the psychological and other aspects of it, we still have a long way to go before that's really going to be the dominant paradigm in the world of medicine. And another big limitation, and this is the reason me and Bob and Cindy wrote this paper, is that life is more than suffering. And so we, I think particularly in medicine, have a kind of a puritanical outlook that everything is kind of defined in terms of suffering. We're very serious, and that's important. But life is certainly a lot more than that, and that's the impetus for this talk, and where I think thinking about joy can become a very powerful tool for researchers and clinicians and advocates. We're starting off with a deficit mindset. So this quote, if all you ever focuses on is the negative, then that's all you ever see. And this is actually part of how I got into positive medicine, is that when we were doing studies and we were giving people our typical quality of life questionnaires and depression questionnaires and caregiver burden questionnaires, everything was measured from 0 to what I would call -10 or negative crap. And we weren't looking at all on the positive side. And when people were filling out these surveys and questionnaires, they were telling our coordinators that they felt worse after filling them out. And I think, this almost exclusive obsessive focus on depression, on pain, on burden, that in and of itself causes a price. And it also causes us, I think, to miss half of life. And in some ways, I would say the better half of life, by being so focused on the negative side of things. So this takes us to this third model of person-centered care, which absolutely builds on this patient-centered and palliative framework, but it embraces the person living with a serious illness rather than defining them by their illness. So the key distinction there is that the person has an illness rather than the illness defining them, which is what patient, essentially means, is that they are defined by their illness, they're defined by their suffering. And life with a serious illness or without a serious illness, that there's certainly life beyond it. And that includes joy, it includes meaning, it includes connection, it includes the ability to grow even when we have serious illnesses, or maybe even particularly when we have serious illness. And there's been a number of writers, Michael J. Fox is the first one coming to mind for me, who described their growth as a person that was really spurned by their illness. And lastly, the idea of healing or wholeness, which is kind of a counterpoint to the biomedical model of cure. But how do we find a sense of healing and wholeness with an illness as opposed to despite an illness? And this is kind of going against the idea of rehabilitation, which is not always possible. We can't always get back to an old sense of normal. So how do we move forward into a new sense of normal and a new sense of being a complete person despite having an illness? Quality of life has both positive and negative dimensions. And from the World Health Organization, they recognize that. Most of our focus has been on the negative side, but I think it's important to make 2 points. One is that these dimensions are not continuous. So if you think about pain and pleasure, or if you think about happiness and sadness, there are some qualitative differences. And part of how you know that is that you can experience pain and pleasure sometimes at the same time. An example might be getting tickled, or an example might be crying at a wedding. And the other aspect of that is that these two dimensions are not absolutely dependent on each other. There are certainly situations where reducing pain may allow one to have more pleasure. An example of that clinically, which I take advantage of a lot, is when I use opiates or narcotics for people with chronic pain. When I start them, I'll ask people to use them in a very specific way, namely take them a half hour before something you enjoy. So take it a half hour before your grandchild's soccer game. And in that way, we can alleviate pain as a means of at least opening up the opportunity to experience pleasure. But there are also times where we might not be able to get rid of something that's painful, but we can still add pleasure. So somebody maybe, has pain that we're not able to treat, and I might encourage them to spend more time outside, or encourage them to go to a favorite spot in nature. The pain may not go away, but the experience of pleasure, the meaning of that, the freedom of that, may allow them to feel better. And so we are able to work with both of these dimensions independently. And so this is a long-winded way of saying is that we can't treat these as simply items on a single scale, and we can't trust that simply getting rid of pain or depression is going to necessarily improve the positive aspects of one's life. I guess one last thing to say about that is about antidepressants. And there are a number of people, a lot of artists, as an example, who avoid antidepressants. And I'm not saying this is always a good idea, but some people will avoid antidepressants because they miss having both the highs and lows of life. And so getting rid of depression and getting into a middle zone where you're not feeling anything or you're apathetic is oftentimes worse than being able to experience the full range of positive and negative emotions. So as we just said, so optimizing quality of life is more than just relieving suffering. Positive and negative emotions can coexist. Eliminating negative stimuli does not necessarily bring positive affect. And this goes back again to why I encourage people, if they're using opiates, to use that time for something meaningful, is that taking an opiate by itself and relieving pain is not going to bring pleasure unless you're taking advantage of that opportunity. The flip side of it, and this is again not always true, but is often true, is that if you can generate positive stimuli, whether that be happiness, love, joy, meaning, that it may be able to bring respite from negative emotions. When we talk about joy, and I think this may surprise some people even that we have the title of this talk, is it's a very serious topic. This is a quote from the Book of Joy from the Dalai Lama and Desmond Tutu. Exploring joy is nothing less than exploring what makes the human experience satisfying. And most religious traditions, not all, but most religious traditions, and certainly a lot of spiritual striving, is about finding joy. And joy is distinct in a lot of ways from finding meaning, that there are things such as seeing a sunset, holding a baby, listening to music that we can't explain, that we can't put into terms of meaning, but are nonetheless reasons that we get up in the morning. The flip side of this, of it being a serious topic, is that the number one reason that people report for asking for medical aid and dying, which is really the bottom of despair, is that they are no longer able to experience joy. Which I think also speaks volumes to how serious an issue joy is, so that we really need to maintain people's ability to experience joy in addition to trying to promote it directly. Joy helps us get through the darkest of times, and as I was doing research for the paper that we published, it was interesting to find that tweets about joy increased substantially at the beginning part of the pandemic, and that was just because that was when the study was published. I don't know if that's continued. But I do know is that almost no matter where you looked, whether it was the New York Times, local departments, friends, that people were very conscious about trying to find more opportunities for joy. And this is a natural human instinct, and it persists even in the face of serious illness. So there's absolutely room for joy in serious illness. This can be, as in this picture, with pet therapy, could be with music therapy, can be with art. But by not drawing on joyful interventions, we miss huge opportunities to improve the quality of life of people who are living with serious illness. And I know there's an instinct, because I've felt this as well, of who am I to bring up joy with somebody who is seriously ill, that we may feel guilty or uncomfortable about doing that. And we are not telling you to try to put a positive spin on somebody's experience, but we are saying, or I am saying, that there is an opportunity that you can bring up the topic of joy and see if people are interested in pursuing it. And not doing so, I think, closes us off and closes our patients off to a lot of opportunity for good or better outcomes. We all have experience with positive interventions, and we have these experiences as friends and through friendship. So when I'm not acting as a doctor, if I have a friend who is experiencing a tough time, maybe we'll watch a funny movie together. Maybe I'll share some stories with them. We have a natural impulse to, certainly acknowledge sadness and suffering, but also to try to bring some levity and light and humor into situations. And I think the world of medicine can benefit from this natural instinct instead of suppressing it. To try to really operationalize things, I think if we're going to conceptualize joy in a medical context, we can use the work of Eric Cassell in suffering and look at joy as a positive counterpoint to suffering. And so just like suffering is subjective, it's self-defined, we can also look at the same thing regarding joy. And as a very quick definition, I would say joy is that which separates living from survival. So those things, for example, from getting calories to having a meal, from having a sitter to having a companion, all of these things that we define as meaningful, we define as living, I think could fit under this umbrella of joy. It's absolutely going to be defined by the individual, and it's hard to predict. And some of examples from my own work, a gentleman who comes to mind who was a professional pianist, and all his life experienced great joy playing the piano, but as he developed multiple sclerosis and was unable to play at that same high level, piano music, not even playing, but just listening to piano, became a source of pain and suffering to him because it reminded him of his losses. And so it's hard to predict what's going to bring joy to a particular individual and what's going to bring suffering. That being said, in Rochester in particular, I've noted that things that maybe didn't used to bring joy, I would put them under the category of just ordinary things, can become a source of joy with serious illness. And so a lot of times when I ask people what they enjoy or they look forward to, it's being around family, it's cleaning, it's getting outside of the house, it's things that they used to take for granted. And now because this illness has slowed their life down, are now taken as profound sources of joy for them. And it may change over the course of an illness. So it's really our job to check in with people and to ask them to guide us in terms of where the opportunities for joy may lie. From a paper that was looking at defining the construct, these were some of the ideas that came under joy. So vitality, inspiration, light are words that are used to describe joy, freedom and spontaneity, expansiveness and connection, hope. And in writing the paper, we actually got some good feedback from reviewers that joy can have both a loud and a jubilant aspect to it, but joy can also be very personal and very quiet. And joy, covers this whole spectrum. So it can be something that's very outgoing, and it could be something that's very private and internal. Joy can be a powerful tool in the practice of medicine, and a couple of stories from Colorado, which I may have shared before, I think speak to this. One was a woman that we saw there who was in her mid-30s. She was a mother, and she was quadriplegic from her progressive MS, and it was a horrible illness. And despite that, she had one of the best smiles of anyone I've ever seen, and her husband described her as hell on wheels. And she would do quad skiing, and our social worker, because it was one of the things that she really wanted to do, got her connected with a group that did skydiving for people with quadriplegia. And her husband wanted nothing to do with it, but he was very supportive of his wife doing it. And, her smile really lit up the room afterwards. That was not something that I, was smart enough to intend to do, but, through our social worker started getting me thinking about, can we do more interventions that bring joy into people's lives? The second one also kind of came up unexpectedly, was working with a patient and a family who was requesting medical aid in dying in the setting of corticobasal syndrome. And when our chaplain was speaking to this woman about what was important to her and what she wanted to do before she died, he was asking her about her family, which was the most important thing to her. And he asked her, how much more time would you like with them? And she stared at him like he was a fool and said, as much time as possible. And that moment really changed the conversation, and it changed the direction things went. So we ended up supporting her in hospice actually for months. She did eventually use medical aid in dying, but she used it a lot later because we were able to focus on sources of joy for her. So really emphasize the importance of joy as a tool in the practice of medicine. And this has evolved into our note template. So in palliative care, or in neuropalliative care, at least in Colorado and here, we're looking not just at sources of suffering, but also explicitly looking at opportunities for joy as part of our assessment. And I've been thinking about kind of a counterpoint to Cicely Saunders' total pain of illness, to possibly something like the total joy of living, and thinking about it and looking at it in terms of different dimensions. So there's a social and a family dimension. Spirituality and meaning can be a source of joy. Simple physical pleasure, even eating more of one's favorite food is one of my favorite interventions for people and for myself. Being around nature, art and music, simply being alive, seeing the sunrise, seeing the sunset. Giving to others absolutely can be a source of joy, and something that we often overlook when we're working with people with serious illness, and is kind of finding its way into our volunteer program of how can we allow people with serious illness to still be able to have the joy of giving. And so really thinking about joy in all of these dimensions and making sure that we don't miss opportunities simply because somebody has a serious illness. Practically, how do we do this? So we can go beyond goals of care to discuss life goals. And these are some of my favorite questions when I get to know somebody and when I see people in clinic. What do you enjoy? What are you looking forward to? And tell me about your life before this illness. And this accomplishes two really important things for me. One is it does tell us about opportunities for joy. And if things come up later that are hard, oftentimes we'll circle back around and see, can we bring nature back into your life? Can we bring some of these activities that were important back into your life? Secondly, and this gets to this idea of joy being just a critically important part of feeling alive, is that if people say they don't enjoy anything, aren't looking forward to anything, I get really worried. And I found that saying no to that question, can be, certainly a sign that we need to bring Sue Ouellette, our chaplain, in and work with that person on their spiritual well-being. But secondly, it's oftentimes a signal to me that maybe we need to start thinking about hospice. Because when people don't enjoy things, aren't looking forward to things, oftentimes their will to live is significantly diminished. Focusing on the positive may reduce the negative, and this is physiological data on this. So there are a number of studies in both animals and people showing that positive affect, and a lot of these have been done with laughter, with comedy, reduces pain and elevates pain thresholds, also reduces need for pain medications. And our palliative care journal club this week is looking at virtual reality as a way to help treat people with pain in cancer, where we use virtual reality to get people into scenes of nature and other places in their mind where they are more happy and potentially feeling less pain. Positively framed interventions may improve motivation to engage in healthy behaviors. An example of this when I was at the University of Florida was a study which was comparing an exercise intervention to exercise plus cognitive training to using the Wii Fit. And the group that did the best was the group that was using the Wii Fit. And when reflecting upon it, the investigators felt that the key thing there was that the people in the Wii Fit group were having the most fun. And so when we're thinking about things, stopping smoking, diet, exercise, taking medications, if there are ways that we could bring joy and fun into that, that we might be able to improve motivation and so-called compliance with these positive behaviors. Interventions incorporating positive affect may reduce depression. There's now an emerging field, in addition to positive psychology, there's newer is positive psychiatry, which is looking at interventions that incorporate positive affect to reduce symptoms like depression and anxiety. And positive affect is associated with a host of other positive physiological effects, including reducing inflammation, positive effects on the neuroendocrine and cardiovascular system, reducing high blood pressure, reducing cardiovascular risk, improving sleep. And so again, really want to hammer home the idea that joy is serious, and joy has serious physiological benefits that we don't want to overlook. Positive outcomes in serious illness are absolutely possible. And so outside of my anecdotal evidence, there are scales that we can use to measure positive affect, that we can use to measure meaning, that we can use to measure efficacy. And I think it's important that we think about these. As this quote says, on assessment, measure what you value instead of valuing only what you measure. I think the flip side of that is that we often overvalue those things that we can measure and undervalue those things that we're not looking at. And I think the end result of that is that we often miss opportunities to augment joy, to look at the positive side of life, because we're so focused on the things that we are measuring, whether that be depression or pain or falls, and that we're not measuring the flip side of that, which is, how much time have you spent outside? What is the value of your relationships? How much happiness do you experience every day? Judy Moskowitz has been doing this work for years and has shown that positive results of a positive intervention for dementia care partners. So this is a study quoted here from her LEAF intervention, life-enhancing activities for family caregivers, and all of her interventions have a PLANT acronym, which I think is kind of joyful in and of itself. But her program is a 6-week positive emotion program, and it's skills-based. So this includes noticing the positive, mindfulness, small acts of kindness, and the positive results included enhanced positive affect, and that was their primary outcome. Improved quality of life, but I think importantly, and this which was not an explicit goal of the LEAF intervention, was that there was also reduced depression and reduced burden. So by focusing on the positive, they were able to boost the positive, but they also got as a secondary effect a reduction in some of the negative outcomes that we traditionally focus on. At University of Rochester, we are continuing this, and actually we started a new collaborative grant with Judy Moskowitz, where we're using positive framing to try to improve aspects of care partner quality of life and burnout. And so we are building on her previous work to do the social LEAF trial with Kathy Hefner and Sally Norton in the Roybal Center. And the idea behind social leaf is to take the leaf intervention, which was done on a one-on-one basis, and to move it into a group setting. So that's one of the big differences of social leaf, is to be doing this as a group. The second big difference is that we are focusing not just on positive skills, but also on making those positive skills social skills. And I believe that at least part of the isolation that care partners experience is that they oftentimes lead with the negative, or when people talk to them, they feel a pressure to commiserate or share with negative. And I'm not saying that we shouldn't talk about negative aspects of being a care partner or caregiver burden, because those are serious things, but also to allow room and encourage people to talk about potentially positive aspects of things. And if this sounds ridiculous, there have been studies showing that 70 to 90% of care partners do experience some positive aspects of their caregiving experience and would do it again. So I think it's really a framing and a frame shift for us to start emphasizing this positive side of it rather than solely focusing on the negative side. A study that we have coming out and hope to publish this year was asking people with serious illness what really matters to them. And so in this study, which we did as part of our PCORI grant, we had 210 people with advanced Parkinson's, high palliative care needs. And we asked them, as part of the McGill Quality of Life survey, what were the 3 things that most determined their quality of life over the past week. And over half of the responses were positive. There were things like families, other activities, their spiritual life. And so again, if our goal in medicine is to improve quality of life, we're only going to get halfway there if we don't focus on and think about the positive. You can empower patients, and you can actually empower yourself. I'm actually starting to apply this to parenting by including the positive in your approach. And on the parenting side, we often use words of "this is a good kid" or "I'm a good parent," but moving from that, which is really a judgment of good versus bad, to an appreciative thing where everything is positive and it's possible for people to get, everybody to get an A. So, in medicine and in so much of our life, we have a deficit narrative where we focus on what's broken. We rely on experts to fix what's broken. We manage symptoms. We're reducing burden. The asset narrative is focusing on what's working, looking at people's strengths, building self-efficacy, looking at opportunities for meaning and joy, and rather than simply anticipating decline, seeing if we can seek opportunities to grow. One of my favorite questions that I got from a chaplain, Judy Long at UCSF, people have probably heard this from me before, is how would you like to grow through this illness? I've just started reading Pema Chodron's book, Things Fall Apart, but it's one of the main messages of that book is that the current moment is an amazing teacher, and that the edges of our comfort and that the edges of fear and illness can really be teachers that show us a lot about how we can grow and to really deepen our spiritual journey or our lives as spiritual warriors, as she would put it. This is also, I would say, one of the greatest gifts I have as a clinician, is learning from people about their courage, about their wisdom, their grace, their kindness, their humor. And I would miss all of that if I wasn't focused on the asset narrative. So going into some other sources of joy, I did mention meaning, and you may argue that meaning is distinct from joy, but it certainly would fit under this positive medicine framework. So from Viktor Frankl, man's search for meaning, that those who have a why to live can bear with almost any how. And when we are no longer able to change a situation, we are challenged to change ourselves. And so this philosophy, which came out of his life surviving the Holocaust, I think is also applicable to the world of serious illness. And there's quite a few approaches, including narrative therapies and dignity therapies, that have done just that with people with cancer, but also with other illnesses. And so these are some questions that touch on this. What is most important to you at this time in your life? How would you like to grow through this illness? What gifts would you like to impart to those you love? Lisa Schulman, who is at University of Maryland, talks about a spiritual will when her husband was dying of multiple myeloma, and how important it was for him to share those personal gifts with his family. And what parts of this illness can this illness never touch, which is really getting at some of the spiritual aspects of meaning. B.J. Miller, who is shown here, speaks about resilience very eloquently. He became a triple amputee, I believe at age 18 or 19, prior to becoming a doctor. in an accident with a electrical system above a train. And he talks about the shift from rehabilitation, where he was using prosthetics and other things to try to appear and get back to a sense of normalcy, towards healing. And the moment that that happened was actually a moment where he was at a museum and seeing busts from ancient Greece who were missing noses and arms and were looked at as great works of art and that were complete in and of themselves. And that was a really important shift for him. And hearing him speak about it, I got to see him when he visited us in Colorado, was actually a very impactful thing for me to really shift between rehabilitation and cure to an idea of healing as more of a spiritual journey. Isolation and loneliness are big issues in serious illness, and we're seeing them more and more actually with COVID. Loss of social capital is not only common in serious illnesses, but has the same impact on mortality as starting smoking. Just like joy is a serious topic, isolation and loneliness are very serious topics, and probably ones that we don't talk about enough. Chronic illness has the capacity to erode primary relationships. It can erode secondary relationships, and as I mentioned, isolation is associated with a lot of poor outcomes. And so the positive side of that is that people can be part of the medicine. So not only asking about social supports and relationships, but encouraging social connections, encouraging people to reach out. Again, one of the joys of my work has been how often neighbors, friends, family members do come forward to help. It certainly doesn't happen all the time, but it does happen more than people expect. And don't undervalue your own connection with that individual, that you are also part of the medicine. And I know from receiving letters from people after they've passed away and their families that I have made a difference in people's lives, not necessarily through anything magical I've done or a diagnosis, but simply by being there as a presence and sharing that journey with them. So you can practice positive medicine, whatever your role. And in this quote from Dame Cicely Saunders, it's not only helping people to die, but also to live until you die, really stressing living as opposed to surviving. And we may not be able to control how much time we have, but we can control what we do with that time. And that's really become part of my mindset, particularly working with somebody with ALS, somebody with brain cancer, where we don't have a lot of time, is how can we make this the most meaningful year, the most joyful year of this person's life? How can we have as few regrets as possible? So really very actively looking for opportunities for joy, meaning, and connection, and ways to promote resiliency for the person with illness and for their family. And to circle back around to us as professionals, maybe some of the advocates, is joy being a missing ingredient in our conversations about burnout, about wellness, and about resilience. But how can we focus on the most rewarding aspects of our own practice and really practicing what I'm preaching here, which is trying to find joy in my own work, finding those aspects of my day-to-day life that I find fun, trying to maximize those, whether that be teaching, research, seeing patients, all of the above, and really focusing on those aspects that bring a smile to my face. Fred Rogers has always been a hero of mine. I like this quote. I'm not going to read through it, but I just want to emphasize this last part of the sentence, which is that each one of us is a giver and a receiver. And I think in the practice of joy in medicine, that joy that we experience is joy that we share with others and vice versa. And so there's this opportunity for us to really amplify joy, love, connection, and meaning by working in this space. There are research opportunities. I'm happy to talk more about these with people. And in my first presidential address for the International Neuropalliative Care Society, talked about positive interventions as something that I think is going to be a standard part of care and research and is part of the future of medicine and the future of neuropalliative care. For people who haven't joined already, I just put in a plug here to think about joining the International Neuropalliative Care Society. Our department will sponsor you if paying for membership is an issue. And just as to wrap up with key takeaways and give about 10 minutes for discussion, I hope I've convinced you that you can increase your efficacy and your effectiveness as a healthcare provider through patient-centered and person-centered approaches, and in particular through thinking about joy, love, and connection as things that you can bring into the clinic space. Positive outcomes matter to people living with serious illness and may also allow people to minimize or cope with negative consequences of illness. And this has important implications, I believe, for research as well as clinical care. And joy, meaning, and connection can be used as tools to steal victories from incurable illnesses.